Every morning, millions of people over 70 wake up, take their blood pressure medication faithfully, check their numbers on their home monitor, see a reading that looks perfectly controlled, and feel genuinely good about themselves. Their doctor is pleased at every appointment. The prescription gets refilled without discussion. By every measurable standard that the medical system has established, they are doing everything right. So why are so many of them falling? Why are so many of them exhausted before the morning is half finished? Why does the mental fog never fully clear no matter how well they slept? Why do they grab the wall every time they stand up too quickly and quietly file it away as just getting older? These are not rhetorical questions. They are the questions I have been asking myself for over 25 years of clinical cardiology practice. And today, I am going to give you the answers that most cardiology appointments simply do not have enough time to deliver. My name is Dr. Katherine. I am a cardiologist with more than 2.5 decades of clinical experience, and I need to tell you something that may fundamentally change how you understand your own blood pressure management. The number you have been working so hard to reach, the target your physician has been guiding you toward with every prescription adjustment and every follow-up appointment, was never designed with your body in mind. Not the body you have now, not the cardiovascular system of someone who has lived past 70. And pursuing that number with the same aggressive precision that is appropriate for a 50-year-old may be costing you something far more significant than you realize. Let me start with a question. When you hear the number 120/80, where do you think that standard came from? Most people reasonably assume it emerged from decades of comprehensive research spanning every age group, every decade of life, carefully tracking outcomes across the full spectrum of human aging until the evidence became undeniable. The actual origin of that benchmark is considerably more uncomfortable than that assumption. The foundational research establishing 120/80 as the universal gold standard was conducted predominantly in middle-aged adults, people in their 40s and 50s, people whose cardiovascular systems were still operating close to their original biological specifications. And within that population, the research was genuinely solid. Lower pressure meant less arterial wear, fewer cardiac events, better long-term outcomes. The science supported the conclusion for that specific group. The problem came in what happened next. Medicine generalized. 120/80 became the number for everyone. Applied to a 65-year-old the same way it was applied to a 45-year-old, applied to an 80-year-old the same way it was applied to someone who had just turned 50. And for decades, the question that nobody asked loudly enough was this: what if the aging body does not simply need a lower pressure target? What if it actually needs a fundamentally different target? Here is what cardiology understands with absolute certainty. After 65, the cardiovascular system undergoes 3 physiological shifts that change how blood pressure must be interpreted and managed. The first is arterial stiffness. Your blood vessels lose elasticity gradually and progressively over time. Think of a brand new rubber band versus one that has been sitting in a desk drawer for 20 years. The old one does not stretch the same way. It does not absorb force the same way. When arteries stiffen, the heart must generate more pressure to move blood effectively through the body. A moderately elevated reading in an older adult is not always pathology. Sometimes it is the cardiovascular system compensating intelligently for a changed physical reality. The second shift involves baroreceptor response time. Your body contains pressure-sensing cells embedded in the walls of major blood vessels whose job is to detect changes in pressure and signal the heart to adjust accordingly. In a younger person, this correction happens almost instantaneously. After 70, that response slows measurably. The sensors are still present and still functional, but their reaction time is longer. The window of vulnerability between a pressure drop and the compensatory response grows wider with every passing decade. The third shift is cerebral autoregulation. Your brain maintains its own internal pressure management system, designed to keep blood flow stable even when overall blood pressure fluctuates. After 70, this system becomes progressively less flexible. It requires a certain minimum pressure to function reliably. Push below that minimum and the brain begins to feel the deficit, not dramatically, not all at once, but quietly and gradually in ways that are very easy to attribute to something else entirely. These 3 changes do not make elevated blood pressure acceptable or safe. Uncontrolled hypertension with readings consistently above 160 remains genuinely dangerous at any age and requires treatment. but they do mean that the floor, the lower boundary below which pressure becomes harmful rather than protective, sits higher in an older body than it does in a younger one. And that changes the entire clinical conversation about what well-controlled actually means for someone in their 70s or 80s. Research published in the Journal of the American Medical Association examined specifically what happens to adults over 75 when blood pressure targets are applied with the same parameters used in younger patients. Real people, real outcomes, tracked over real time. What the researchers found quietly and significantly challenged decades of clinical assumption for this age group. The optimal systolic reading, the top number for the best patient outcomes, was not 120, it was not even 125. The range associated with the lowest rates of hospitalization, the sharpest cognitive function, and the lowest overall mortality sat between 130 and 145 millimeters of mercury. The range where older adults actually did best was measurably higher than the standard target most of them are currently being medicated toward. Let that settle for a moment before we continue. I want to tell you about something I have witnessed more times than I can count across 25 years of cardiology practice. A patient comes in, older adult, 77, 79, perhaps 82. Their blood pressure readings are beautifully controlled. The medication is performing exactly as intended. The numbers sit precisely where the guidelines indicate they should, and then I ask them how they have actually been feeling, and the answer is never quite what the chart would suggest. Tired, a bit unsteady, not quite themselves. Their daughter mentions they seem confused in the evenings. Their son says they have stopped their morning walks because they feel dizzy whenever they stand up. Small things, easy things to attribute to aging, to seasonal changes, to sleep quality. Here is what the research tells us about those small things. Adults over 75 who are treated aggressively toward targets below 120 face a 28% higher risk of serious falls and fractures. 28%. That is not a marginal footnote in a statistical table. That is a clinically significant elevation in risk that in any other clinical context would immediately and substantially change prescribing behavior. I need you to understand what a serious fall means in this population. This is not a stumble. This is not a bruised knee and a shaken confidence. A serious fall at 78 can mean a fractured hip. Emergency surgery, weeks of hospitalization followed by months of rehabilitation if recovery occurs at all. For a significant proportion of older adults, a major fall is not an isolated incident. It is the event that initiates a cascade from which they never fully return to their previous level of function and independence. What makes this particularly difficult to recognize and address is that the fall does not happen in a clinical setting. It happens at home, in the ordinary moments of an ordinary day, getting out of bed at 5:30 in the morning, standing up from the kitchen table after breakfast, rising from the sofa during a commercial break. In each of those moments, blood pressure drops briefly as the circulatory system redistributes against gravity. In a well-medicated older adult whose baseline pressure is already sitting at the low end of their treatment target, that brief drop can be sufficient to cause the room to tilt, the vision to darken at the edges, and a step to be taken before the body is fully ready to take it. The incident goes into the medical record as a mechanical fall, a slip, an accident. The connection to the medication is never drawn, the dose is never reconsidered, and the patient continues taking the pill that is, in a very direct physiological sense, making their world less stable. Think of a fuel gauge, not a modern digital display but an old analog dial with a needle. When the tank is full, the needle has enormous range before it approaches critical territory. You can accelerate up a hill, run the air conditioning, make demands on the engine without concern. The needle drops, but never enters dangerous territory. There is buffer, resilience, room for the unexpected. Now imagine that same gauge sitting permanently just above the empty line. Every small demand on the engine, every hill, every change in driving condition pushes the needle into the red. The car does not stop immediately, but it is operating continuously on the edge of its reserve, with no capacity remaining for anything unpredicted. That is precisely what happens inside the brain of an older adult whose blood pressure is being held at the low end of what medicine has defined as normal. Your brain consumes approximately 20% of your entire body's blood supply, despite representing only about 2% of your body weight. It is the most metabolically demanding organ in your body. And unlike muscle, unlike fat, the brain has essentially no reserve capacity. It requires consistent, adequate, uninterrupted blood flow continuously. When you are lying down, maintaining that flow is relatively straightforward. The moment you stand, everything shifts. Blood moves toward the lower body. Pressure at brain level drops momentarily. The body's job in the following 2 to 5 seconds is to detect that drop and correct it before the brain notices the deficit. In a younger person with responsive baroreceptors, that correction happens so rapidly it is never consciously perceived. In an older person whose baseline pressure is already sitting low from medication, that correction window extends. 5 seconds, 6, sometimes longer. During every one of those seconds, the brain is receiving less blood than it requires for optimal function. Just enough to make the edges of vision darken slightly. Just enough to produce an instinctive reach for the nearest solid surface without the person quite understanding why. Most people I have spoken with in clinical practice have experienced this, and almost all of them have categorized it under simply getting older. They have learned to stand more slowly, to pause before walking, to quietly rearrange their morning routines around a dizziness they have come to expect. That adaptation is not wisdom. That is the body communicating something important and the mind finding a workaround rather than listening to the message. Emerging research increasingly suggests that chronic, repeated episodes of low-grade cerebral underperfusion, occurring multiple times every single day, may contribute to accelerated cognitive decline over months and years. The brain run consistently below its optimal blood supply threshold does not perform at its best, and over time that cumulative deficit carries consequences that extend well beyond morning unsteadiness. The next time you experience that momentary lightheadedness when you rise from a chair, do not file it away. Pay attention to it. It may be your body's most direct and honest communication about whether your current medication dose is appropriately calibrated for where you are now. I want to offer you something practical. Something you can do today in your own home with equipment you either already own or can purchase for under $30. Something that will provide more genuinely useful information about your cardiovascular status than most routine office visits. It is called the orthostatic blood pressure test. You need a home blood pressure monitor and a chair. Begin by sitting quietly for 5 full minutes. Not using your phone, not in conversation. Simply sitting still and allowing your circulation to fully settle into its resting state. After 5 minutes, take your blood pressure while still seated. Write down the top number, the systolic reading, and the bottom number. Note the date. Now stand up. Not carefully and slowly the way you may have learned to rise. Stand the way you actually stand in real daily life, the way you would get up from the breakfast table on an ordinary morning. Within 60 seconds of standing, take your blood pressure again and record both numbers. Now compare the two systolic readings. Now let me give you the specific questions to bring to that appointment, because in my experience, patients who arrive knowing exactly what they are asking receive fundamentally different care than those who arrive hoping to be told everything is fine. Knowledge changes the dynamic of the clinical encounter. It changes what gets discussed, what gets measured, and what gets adjusted. Question 1. Given my age specifically, what is the evidence-based systolic target range you are working toward for me, and how does that account for my individual risk of orthostatic hypotension? This question signals that you understand blood pressure management is age-specific and opens the door to the orthostatic discussion, which many physicians do not raise unless the patient introduces it directly. Question 2. I have been doing the sit-to-stand blood pressure test at home, and my systolic drops by approximately this number of points when I stand. Can we measure that here today and factor it into my treatment plan? Data invites clinical thinking. A specific measurement prompts a specific clinical response in a way that a vague description of feeling unsteady simply does not. Question 3. Some of the symptoms I have been experiencing, dizziness on standing, morning fatigue, occasional difficulty with concentration and word retrieval, could these be consistent with my blood pressure running lower than is optimal for my age? This question gives your physician explicit permission to consider overtreatment as a diagnostic possibility. Many clinicians are trained to investigate the consequences of inadequate blood pressure control. The possibility that treatment itself has created a problem often requires the patient to introduce it directly into the conversation. You are not being confrontational by asking these questions. You are being a precise and informed participant in your own care. And in medicine, precision is the difference between an adjustment that meaningfully improves how you feel for the next decade and another year of quietly adapting to symptoms that should never have become normal. I have spent 25 years sitting across from patients who have faithfully managed their blood pressure, taken every pill on schedule, attended every appointment, done everything right by every conventional measure, and they feel persistently, quietly worse than they did before their numbers were so perfectly controlled. They do not connect the two things because no one has ever suggested that the connection might exist. Their physician looks at the reading, nods with approval, and moves forward to the next item on the checklist. The 28% increase in fall risk I cited earlier is not an abstraction. It is real people. People with the same medication in the cabinet and the same reading on the monitor, experiencing fractures, hospitalizations, and the beginning of functional declines that did not have to happen. Not because their physician was careless or indifferent, because the target was wrong for their age and the specific conversation that would have identified that was never had. A serious hip fracture at 78 is not a minor medical setback. For roughly 1 in 5 older adults, a major hip fracture is associated with death within the following year. Not from the fracture itself, but from the cascade of complications that hospitalization and immobility initiate. Pneumonia, blood clots, accelerated muscle loss, hospital-acquired infections. Every one of those outcomes begins with a moment that lasted less than 10 seconds, a pressure drop, a brief darkening at the edge of vision, one step taken before the body was ready. That moment is preventable. The conversation that prevents it takes 15 minutes, and you now have everything you need to initiate it. This week, I am asking you to do 3 things. Perform the sit-to-stand test at home, write the numbers down with the date, and book an appointment with your physician. Not to argue, not to demand a specific outcome. To collaborate, to bring a more complete picture of what your daily experience actually looks like into the room where decisions about your health are being made. Share this video with someone you care about who is over 65 and managing blood pressure. Subscribe to this channel for evidence-based cardiology content that specifically accounts for the biology of aging rather than applying a universal standard across every decade of life. And please remember that everything I have shared today is general educational information, not personal medical advice. Your individual history, your kidney function, any prior cardiac events, your specific medication profile, all of that must be factored into any changes to your treatment. What this information gives you is a foundation, a reason to ask, a basis for a conversation that is specific rather than general. Specific conversations produce specific answers, and specific answers are where the real change in how you feel begins. Take good care of yourselves. I am Dr. Katherine, and I will see you in the next video.